Yes, Reena, you can take over.
Thank you, Trupti. I add Dr. Reena Rathi, Secretary, Nasik Adolescent Health Academy. Welcome you all to our fifth session of PATH, that is Pediatrician Action for Teenagers Healthcare. This concept started with our president's idea, Dr. Ramakant Patel sir and Secretary Dr. Amol Pawar sir, which is very well implemented and going on with the guidance, and it's under the guidance of Dr. Atul Kanikar sir. We are very thankful for it, sir. Today, for our fifth session, we have two very well-known speakers from Trivey Ananthapuram, Dr. Arun Nair sir and Dr. M.K.C. Nair sir. We are just waiting for their talk on the above topic. Arun Nair sir is going to talk on psychopharmacology in adolescents, and M.K.C. Nair sir is going to talk on counseling of adolescents in OPD for pediatricians. I welcome our both speaker, M.K.C. Nair sir, Dr. Arun Nair sir, our Geeta Patil ma'am, Dr. Kanikar sir, President Nasik Adolescent Health Academy, Dr. Sucheta ma'am, Dr. Sadachar sir, Dr. Swati Gharte ma'am, Dr. Ramakant Patil sir, Dr. Amol Pawar sir, and Dr. Trupti Mahatme. Dr. R.N. Sharma sir is also there. Sir, please, I also welcome you. With that, I'm going to hand over mic to Dr. Atul Kanikar sir, who is the brain behind this. Atul sir, over to you.
I'm sure you won't be starved, madam. I have a little bit of brain, so utna bhi mat khao. Actually, this is all a very good concept, and it could have been done, quite a few years ago. That now more and more pediatricians are entering into the field of adolescent pediatrics, and thanks to our legends like M.K.C. Nair sir and Swati Bhave madam, C.P. Bansal sir, Tuteja sir, and so many people who have been promoting this particular concept for general pediatricians throughout the country. So all this has been taken up by our state president, Dr. Patil, Ramakant Patil, and my very good, enthusiastic, energetic friend, Dr. Amol Pawar from Nasik AHA, which is a rising branch. I'm sure it will touch the skies in next few years because of all these enthusiastic people from Nasik AHA. So monthly we have first Sunday meetings 11 to 12:30, and every month we are having some different topics useful for the practicing pediatricians in day-to-day care. As far as the teenage well-being, which is our target, physical, mental, and social, and spiritual also. So today we have this fifth lecture, and M.K.C. Nair sir, I am sure he will be coming one more time this academic year of Maha-AP. So I think for the formal introduction of Arun B. Nair sir, we have been recently in email contact since last maybe 2-3 weeks for that e-newsletter of IIP, Child India. And he has written the same topic of psychopharmacology for teenagers, pediatricians, and he's going to talk on that. So over to you, madam, for his formal introduction of Arun B. Nair sir.
Thank you, sir. Thank you for your guidance. Dr. Arun Nair sir, when I read his CV, it is just excellent. There is no word. And we are very fortunate to have sir for the topic psychopharmacology in adolescents. Dr. Arun Nair sir is a professor of psychiatry, Medical College of Trivandrum, honorary consultant psychiatrist, Sri Chitra Trivandrum Institute of Medical Science and Technology. Sir is author of 18 books, including Advances in Psychiatry and Medicine, and Live, Learn, Look Bright. He conducted not 1, 2, or hundreds, more than 2,000 episodes of health and family welfare programs for various TV channels. Sir was a judge of the reality show Made for Each Other in Manorama TV, and the Civil Service Interview Model Program, 1 in Million, in Amrita TV. Sir has conducted more than 500 talks for All India Radio. Sir has published research papers on mood disorders, psychosomatic disorders, child abuse, suicides, and vitamin D, and many more. Has delivered lectures at several international and national psychiatric conferences. Sir is a guest faculty at Kerala Judicial Academy, High Court of Kerala, and at many other places. Sir has received several awards, including Vocational Excellence Award of Rotary International, Mano Seva Ratna Puraskar, P. Kesana Discipline Award, Mind Award, Social Media Award, and many more. He is certified by Asian Book of Records for the largest suicide prevention radio program across the nation. We are very fortunate to have you, sir, as a speaker for us. Thank you very much for accepting our invitation. Over to you, sir.
Thank you very much, ma'am, for your very kind introductory words. Hope I'm audible and visible to everybody there.
Yes,
and
sir.
It's really wonderful and commendable that pediatricians are taking up the responsibility of adolescent mental health care also, because always people have a stigma attached to mental health problems and they find it difficult to approach a psychiatrist. So if a pediatrician does the job of identifying and treating some of the common mental disorders which are seen in the adolescent age, that can do a lot of good for the adolescent population. So I'll start sharing my screen. Hope my slide is visible. So topic is psychopharmacology in adolescents. So talking about adolescents, as we all know, 50% of all mental health problems begin before 14 years of age. That is what the WHO statistics say. And 75% of all mental health problems begin before 24 years of age. So probably adolescence is the key age at which many of these mental health problems start showing its early manifestations. So early identification and treatment is the key to cure, to recovery, and reducing disability for the future. But the problem here is that 80% of the psychotropic drugs, psychopharmacological agents, which are used in adults, they are not approved by the Food and Drug Administration of USA in children. Only 20% of the psychopharmacological agents are approved for use in children and adolescents. I shall specify those which are approved and would specify those which are given off-label for the treatment of behavioral problems. Of course, a note of caution is that pharmacotherapy alone may not yield the best results. A combination of pharmacotherapy plus psychotherapy may be better. As Professor MKC sir is lecturing on counseling of adolescents, I'm sure imbibing a little bit of those skills also may go a long way in imparting the best results for adolescents. So when we talk about adolescent psychopharmacology, a few things to be kept in mind is most of the psychopharmacological agents are lipophilic medications. Quite a large number of them have got interactions at the level of cytochrome P450 enzyme system. And liver metabolism and renal metabolism. Some of these agents are metabolized through the liver, some others through the kidney. So basic knowledge about these factors, the extent of lipophilic nature of the medicines, the common drug interactions at the level of CYP450 enzyme system, the metabolic pathway, whether it is renal or liver metabolism. These would be extremely beneficial while prescribing these agents. So coming to adolescent behavioral problems, we can broadly classify adolescent behavioral problems under three headings. First is the neurodevelopmental problems. Neurodevelopmental problems are the disorders in the development of the brain appropriate to the age. They include intellectual developmental disorder, which is the new terminology for mental retardation, autism spectrum disorders, which is the new terminology for pervasive developmental disorders, specific learning disorders, as well as attention deficit hyperactivity disorder. We shall examine the impact of psychopharmacological agents on each one of these disorders subsequently. Second category is externalizing disorders. These are a group of disorders in which the children and adolescents demonstrate behavioral problems which amount to public nuisance, which amount to offending tranquility of public spaces. And these include conduct disorder, oppositional defiant disorder, and intermittent explosive disorder. Then we have a large number of internalizing disorders. In internalizing disorders, there is absolutely no display of aggression or violence or public nuisance from the part of the adolescent, but the adolescent is suffering too much. He's contemplating suicide, he's unable to study, he is having racing thoughts in his mind, which is distracting his attention from what he's supposed to do. Depressive disorders, anxiety disorders, obsessive compulsive disorders, psychosis, substance use disorders. New generation synthetic drugs are very much used by adolescents these days. I'll put in a slide about the pharmacological management of them also. And finally, behavioral addictions. Behavioral addictions means just like substance addiction, repetitive behaviors, watching an online game or playing an online game, watching pornography, chatting through dating apps. All these can be addictives, and they form what you call behavioral addictions. These are the common behavioral problems seen in adolescents. So let us start with the commonest behavioral problem, which is.
Sir, I am extremely sorry to interrupt, but your video, I think, is off and I cannot see your beautiful face on the screen.
Okay. Let me see, sir. I'll 1 minute.
It's good to see the speaker also as you listen to him. Now I can see you, sir.
Okay. Is it okay, sir?
Yeah, now
Right.
It's okay. Yeah.
Okay. So now we come to the most important behavioral problem seen in adolescents and children of the school-going age, ADHD, attention deficit hyperactivity disorder, is seen in 7.
Sir, again, sorry, but now please share your screen, sir. Now your
Okay.
again your face is not visible now. But anyway, you can talk, sir. We'll just listen to you. Yeah.
Okay. So attention deficit hyperactivity disorder, that's the commonest behavioral problem seen in school-going children. 7 to 10% of school-going children suffer from ADHD as per the current statistics. And the common medications which are useful for ADHD can be divided into 2 classes: stimulant medications and non-stimulant medications. So the commonest stimulant medication which is available in our part of the world is methylphenidate, which is supposed to be the drug of choice for ADHD. The action of stimulant medications is they enhance the level of dopamine in the prefrontal cortex or the mesocortical dopamine circuit, thereby enhancing the attention span. They also help in improving the coordination between the 2 cerebral hemispheres of the brain, whereby they improve the hyperactivity as well as the impulsivity. Methylphenidate is available as plain tablets, 5, 10, and 20 milligrams, as well as extended release tablets, 10 milligram, 18 milligram, 20 milligram, 36 milligram, and 54 milligram, depending upon the company which is releasing it. The original research molecule was identified as 10, 18, 36, and 54 milligram tablets. And one of the international brands called Concerta, which is marketed by Johnson & Johnson, that is available as 10, 18, 50, 36, and 54 milligrams, but definitely much more costlier than the Indian brands. Many Indian brands are available as 10 milligram, 5 milligram plain tablets, 18 milligram, 20 milligram, 36 milligram, and 40 milligram once daily formulations. So what should we be careful about while prescribing methylphenidate? Methylphenidate is a Schedule X drug, which means it needs double prescription with seal. One prescription is to be kept with the person who is purchasing it, and the second prescription with seal of the consultant has to be handed over to the pharmacy, and they are supposed to keep it in file and report it to the drugs controller every month. The reason is that it's a performance enhancing agent. So in foreign countries, there used to be a time when there is any competitive examination or interviews, people used to take methylphenidate at high doses. But things to be cautious before prescribing methylphenidate is we have to do a blood workup, specifically renal function test. An ECG should be done at baseline. Anybody with any history of arrhythmia, methylphenidate is best avoided. Anybody with deranged renal function, methylphenidate is best avoided. And one another thing is that methylphenidate can produce growth retardation in the long run. So every follow-up, you have to evaluate the patient for the height, weight, and whether the development is appropriate to the age. If there is any developmental problems, definitely we can substitute methylphenidate with any other drug. I'm mentioning only the common adverse effects which are observable in day-to-day clinical practice. Hundreds of adverse effects are mentioned, but these are the things we should keep in mind. So there used to be one example I would share with you, a clinical case I would share with you. There was this boy who was 8 years of age, who was living with his parents in Dubai, but come for vacation. Severe ADHD with hyperphagia. He would demand for junk food items and he would continue to eat it. Then he would sit in front of a PlayStation and play for hours. And whenever he's not sitting in front of the PlayStation, he's extremely violent, aggressive, hyperactive, and disruptive. He came to me. I prescribed him methylphenidate because he was an ideal candidate for methylphenidate. I prescribed methylphenidate for 1 week and asked them to come back after 1 week. But they just disappeared. Because that happens. Many often, people are not very comfortable with starting drugs for a child, so they may disappear. But what happened was that this child returned after 1 year during the next summer vacation season. But I could not even identify that boy. The boy at the age of 8 was very chubby, very fat and extremely hyperactive and very voracious eater. After 1 year had reduced to a bundle of bones. I did not understand what had happened, but it was when the parent described what had transpired, which I understood what had actually happened. What happened was that the child started taking methylphenidate, and within 5 to 6 days itself, there was some improvement. So since they were in a hurry to go back, what they did was that they just changed the date of the prescription, and instead of 1 week, they modified it as 1 year and purchased the medicine from somewhere else. And they gave the prescription which I had given to them to the pharmacy, telling them that they have another copy of the prescription with them. This is to be kept at your shop. They got it for 1 year and left. So never prescribe methylphenidate for prolonged periods of time. It's sure to produce appetite suppression and growth retardation. Maybe you can prescribe it for 1 week, review after a week, maybe after that for once in 2 weeks. At least once in a month, you should review the patient if the patient is on methylphenidate. Not good to prescribe methylphenidate for extended periods of time because you may never know whether the adverse effects are happening or not. How long should you give methylphenidate? That is another question. In my experience, what I say is that for an amount of almost 18 months, if proper treatment is given for 18 months, 80% of the people with ADHD achieve a state of remission. 20% cases will be there who will be really difficult cases for whom we may have to continue it for an extended period of time. There are consultants who believe in the concept of drug holiday for the treatment of ADHD. Means they'll be giving methylphenidate only on working days, only on weekdays. On Saturday and Sunday, they ask the client not to give methylphenidate. During vacation season, during summer vacation season, they ask the parents not to give methylphenidate. But I don't subscribe to that from my practice because what I say is that if you give it for 5 days and then break it for 2 weeks, the child will be back to square one during the Saturday and Sunday. And that will lead to conflict between the parents and the kid. And they may worsen the dynamics of the relationship. And that will affect the treatment and care of the child in the long run. So I prefer continued prescription of methylphenidate for a period of time, then slow tapering and stopping. So if the person cannot afford methylphenidate, go to the second line of drugs, which include atomoxetine, clonidine, modafinil, and then the third line of treatment using antipsychotics. Atomoxetine is again a norepinephrine dopamine reuptake inhibitor, which enhances the level of both norepinephrine and dopamine in the prefrontal cortex, improving attention span. The difference in the efficacy between methylphenidate and atomoxetine is that methylphenidate is better useful for all the three domains of ADHD, including inattention, hyperactivity, and impulsivity, while atomoxetine is more useful for inattentive subtype of ADHD. It may not improve impulsivity and hyperactivity to that extent. Atomoxetine is available as 10, 18, 25, and 40 milligrams. It has to be prescribed in the morning. All these drugs, whether it is methylphenidate or atomoxetine or modafinil, it should be prescribed in the morning, because the common factor between these three drugs is that they are attention enhancing agents. They promote alertness, so they may produce insomnia. So if you give it at night, insomnia can be a problem. So give atomoxetine also in the morning. One common adverse effect which atomoxetine consuming patients present with is these kids may have appetite suppression, anorexia, weight loss. And some of them, a small subset of them, may have mood symptoms, depressive symptoms. And very rarely we have seen kids presenting with suicidal ideas even on atomoxetine. If any such symptoms are manifested, just stop atomoxetine and go to another drug. Modafinil is again some dopamine enhancer at the level of prefrontal cortex. It is the drug of choice for narcolepsy, which is a hypersomnolent state. So when it is given in the morning, it improves alertness, wakefulness during the day, and it enhances attention span also. One problem with modafinil is that modafinil may produce migraine in people who are susceptible to developing migraine, and it may produce a little bit of gastritis also. Clonidine is a drug which can, all these drugs, methylphenidate, atomoxetine, modafinil, all of them are better prescribed after 6 years of age. So do you want to give pharmacotherapy for a child less than 6 years of age? It's a big question. Of course, recently I had a 2.5-year-old kid with ADHD, severe ADHD to the extent that he's not even able to sit for a single second. He is staying in the 13th floor of an apartment complex and he is trying to jump from that. So what should you do? There is no way out. The parents are finding it extremely difficult. So we may have to give pharmacotherapy at least for a short span of time so that we can teach them the parenting and psychological techniques and give them some space and time to implement them. In such cases, clonidine may be useful. Clonidine 0.1 milligram or 100 micrograms is available. Can start at a dose of 1/4 tablet twice daily, maybe slowly increase it to half, then 1 tablet like that. So should understand that, of course, clonidine is an antihypertensive. So BP has to be monitored on every visit. And sudden stoppage of clonidine from a higher dose is not recommended because it can produce rebound hypertension. So clonidine, if you're stopping it, it should be tapered and stopped. Antipsychotics, risperidone, aripiprazole, and haloperidol at a low dose may be given for severe resistant forms of ADHD not responding to other two. We shall come to the dosage and precautions of antipsychotics subsequently. So coming to depression, depression is very common among adolescents, and adolescent depression can present with aggression and agitation rather than sadness, noise intolerance, frequent quarrels, self-injurious behaviors. These may be the manifestation of depression in adolescents rather than sadness, melancholia, sitting still, etc. So the antidepressant drugs which are commonly used, which are approved by the FDA, include SSRIs, selective serotonin reuptake inhibitors. And the selective serotonin reuptake inhibitors which are approved by FDA include fluoxetine, fluoxamine, sertraline, and escitalopram. Out of these, only 2 drugs have been approved for the use in major depressive disorder, that is escitalopram and fluoxetine. So fluoxetine is available in liquid formulations, 20 milligrams per 5 ml. In small kids less than 10 years of age, you can start at 2.5 ml in the morning, that is 10 milligrams daily morning, and gradually increase it to 5 ml in the morning, that is 20 milligrams. And fluoxetine has got a long half-life. So it starts its action slowly. It may take at least 2 weeks to establish its action. And even after stopping the drug for the next 2 weeks, the antidepressant action may remain. But the problem with fluoxetine is that it has got significant interactions at the level of CYP1A2 and 2D6 enzyme systems. And some of the common interactions with fluoxetine. Number one is fluoxetine has got interaction with beta blockers. Fluoxetine has got interaction with statins. So statins may not be a problem in children, but nowadays we see even adolescents because of obesity and issues. I see a lot of prescriptions in them in which people with metabolic syndrome in obesity are put on, and obesity in adolescents are put on statins. Fluoxetine will inhibit the metabolism of statins. As a result, the serum level of statins may go up. So if you co-prescribe fluoxetine and statins, there can be liver toxicity, there can be myopathy, there can be rhabdomyolysis. So from that angle, escitalopram appears to be a safer drug because escitalopram does not have any interaction at the level of CYP. It can be very safely co-prescribed with any other drug in the world. Absolutely no problem. Escitalopram is available as 5, 10, and 20 milligrams. 5 milligram to begin with. Maybe 10 milligram will give optimum response. Rare cases, we may have to increase the dose to 20 milligrams. So here again, fluoxetine has got interaction with beta blockers also. Fluoxetine increases the serum level of beta blockers. So bradycardia, hypotension, falls, etc. may be possible when fluoxetine is co-prescribed with beta blockers. But escitalopram beta blocker combination does not have such an issue. And 2 other SSRIs which are approved for obsessive compulsive disorder, not for depression, they are fluoxamine and sertraline. Fluoxamine is available as 25, 50, 100, and 150 milligram tablets. At a dose of 100 to 300 milligrams per day, they are very effective for the treatment of obsessive compulsive disorder. Sertraline again is available as 25, 50, and 100 milligrams. At a dose of 50 to 150 milligrams per day, they are very effective for the treatment of obsessive compulsive disorders. SNRIs are not approved for use in adolescents, but for those adolescents with severe somatic symptoms, pain symptoms, dissociative convulsion kind of symptoms, hyperventilation kind of symptoms. So they are very anxious, they are depressed, but the predominant manifestation is physical symptoms. They need a modulation of the norepinephrine system in the brain. So SNRIs like desvenlafaxine or venlafaxine may prove. Tricyclic antidepressants, again, some of them are approved for use in child cases also. The first drug which was approved for use was imipramine for the use of nocturnal enuresis in kids. Nowadays, amitriptyline and clomipramine are approved for the treatment of depression in kids, and clomipramine is approved for the treatment of obsessive compulsive disorder also. But all these tricyclics have got some problems. They have very powerful anticholinergic adverse effects. They can worsen cognition in children. They can produce urinary retention, constipation, and a whole lot of adverse effects. And if the child has got any cardiac arrhythmias, they can worsen cardiac arrhythmia because some of these tricyclics, especially amitriptyline, they've got an action similar to type 1A anti-arrhythmic drugs, the quinidine group of drugs. So they are best avoided in kids with any cardiac problems. Mood stabilizers. Mood stabilizers are the medicines which are used for the treatment of bipolar mood disorders. They include lithium, sodium valproate, carbamazepine, lamotrigine, and some of the recent molecules, including endoxifen. Here, lithium is the classical mood stabilizer. It is approved for use in adolescents also. But I would recommend that you may refrain from prescribing lithium because lithium is a complicated molecule which can lead to toxicity. So if you are prescribing lithium, 300 milligrams BD may be the beginning dose. After giving it for 5 days, definitely check serum lithium because lithium has got something called a therapeutic window. It is efficacious at 0.6 to 1.2 milliequivalents per liter. For acute mania, 0.8 to 1.2 milliequivalents per liter is the serum level that is necessary. And for maintenance, 0.6 to 0.8. Lithium has got a very important advantage. It is anti-suicidal in property. It reduces suicidal tendency. But unfortunately, lithium is one of the commonest medicines which are utilized by suicidal patients to commit suicide also because lithium, if it is taken in a very high dose, it can produce cardiac arrhythmias, it can produce central nervous system dysfunction, electrolyte imbalance, renal failure, a whole lot of problems. So if the level of serum lithium is more than 1.5 millicoulombs per liter, it should be immediately stopped and IV fluids have to be given. If it increases beyond 2.5 millicoulombs per liter, even dialysis needs to be done. Often what happens is that during the summer season, people don't take fluids also. When there is dehydration, even with the earlier dose of lithium itself, lithium toxicity is precipitated. Sodium valproate, carbamazepine, and lamotrigine are anti-epileptics also. So they are very commonly used by pediatricians, so you may know better than me. But my concern is about giving these drugs to specific populations. Adolescent females, if they are given sodium valproate, whole lot of issues ranging from polycystic ovarian syndrome to obesity, to diabetes, to rashes, to acne in the face, to hair fall, and a whole lot of cosmetic issues are there. So in most of the Western countries, sodium valproate is not given in reproductive age group females, not only because of these problems, but also because of the teratogenicity issue. Carbamazepine also is much safer than valproate from that angle, but it can produce Stevens-Johnson syndrome. Carbamazepine, oxcarbazepine, eslicarbazepine, all of these have got excellent action on controlling impulsivity, but definitely they have to be prescribed with a mark of caution that it can lead to rashes and it may lead to Stevens-Johnson syndrome. Lamotrigine also may produce Stevens-Johnson syndrome. And endoxifen is a recent molecule, is a congener of tamoxifen, which is a SERM, serotonin receptor modulator, which is useful for the treatment of breast cancer, estrogen receptor positive breast cancer. Endoxifen is a congener of tamoxifen. Now we see that endoxifen is marketed in India for mood disorders. And I have used it in youngsters, especially people working in the entertainment industry who cannot afford adverse effects like rashes, acne, weight gain, hair loss, etc. And from that angle, it is good. So endoxifen at a dose of 8 milligrams in the morning is very useful in people with mood disorders with comorbid substance use, because people from the entertainment industry may be having mood fluctuations with use of substances, including MDMA and a whole lot of other things. So endoxifen functions to reduce the craving for these substances also. So coming to antipsychotics in brief, risperidone, haloperidol, and aripiprazole, these are the commonly used antipsychotics. They are used for the treatment of psychosis, that is hallucinations, delusions, etc. And they are also useful for some other indications like behavioral problems in mental retardation, behavioral problems in autism spectrum disorders, and even for severe ADHD. Risperidone at a dose of 0.25 milligrams to 3 milligrams. Haloperidol at a dose of, say, 0.5 milligram to 2 milligram. And aripiprazole at a dose of 2 milligram to 30 milligram is FDA approved for use in adolescents. But here again, one small thing to be taken into consideration. Risperidone and haloperidol, they are D2 receptor blockers. They increase the level of prolactin. So many adolescent females who are prescribed these molecules may present with amenorrhea and galactorrhea, which may be an even more distressing. Now, galactorrhea is more distressing because imagine a girl sitting in her school classroom developing breast milk secretion. It's so embarrassing and it is creating so much of distress. So if it is an adolescent female, I would request you to prescribe aripiprazole as the first level, because aripiprazole is a dopamine serotonin system stabilizer. That is, when the level of dopamine is high, it will reduce it. In other areas where dopamine is low, it will increase it. So it does not increase prolactin. In fact, it reduces the level of prolactin. So it's a very female-friendly, reproduction-friendly kind of an antipsychotic. So it may be used. But again, we need to be mindful about the adverse effects. People who use aripiprazole at a dose of above 5 milligram per day present with something called akathisia. Akathisia means a sense of subjective restlessness. The person is walking here and there, is unable to sit still. You think that it is a psychotic or manic aggression, but no, it is an adverse effect of aripiprazole. So whenever you prescribe aripiprazole, be careful about the symptom of akathisia. Now, I'm coming to the last 5 minutes of my presentation. Benzodiazepines, are they safe in adolescents? One single sentence, benzodiazepines are a group of drugs in psychiatry with tremendous addiction potential. Commonest benzodiazepines which are used for addiction include nitrazepam and alprazolam. I get quite a lot of adolescents in my practice who are addicted to cannabis, MDMA, etc. And whenever they cannot get enough money to procure these substances, they purchase 5-star chocolate and they just keep nitrazepam tablets into the bar of the chocolate. 3 or 4 nitrazepam tablets are just kept in the bar and they consume it. They find that it is extremely relaxing and that will take care of the withdrawal symptoms associated with not using the stimulant medications like MDMA. So that is one thing. So whenever you prescribe benzodiazepines, go for short-acting benzodiazepines like lorazepam, or if the person has got something like a generalized anxiety disorder which is continuously present from morning till evening, go for an intermediate-acting benzodiazepine like clonazepam. Avoid nitrazepam and alprazolam as much as possible. And we have got lesser addictive benzodiazepines like etizolam. Etizolam is a very light benzodiazepine. Mild sedation is there, it may not impair day-to-day functioning. And we have got one more benzodiazepine which does not have any sedation at all, that is tofisopam. Tofisopam is available as 50 milligram tablets. You can give it in morning, afternoon, and evening. It will cover the anxiety throughout the day. It does not have sedation. It can be given in students for exam anxiety. It can be given to people who are working also without much of a problem. So are beta blockers safe as anxiolytics? That is the next question. Because we know beta blockers don't have much sedation. Of course, if there are no contraindications, if the person does not have asthma or hypotension or cardiac arrhythmias, beta blockers can be given safely, maybe for exam anxiety, stage fright, etc. Short term, 10 milligram plain benzodiazepines can be given. I do prescribe extended release benzodiazepine 20 milligram to kids who attend entrance examinations and all that, because they have to write the exam right from morning till evening. I give extended release formulations 20 milligrams so that the anxiety will be covered till evening. We also have got combinations of benzodiazepine with beta blockers, the single tablets. Etizolam propranolol combination is available. Clonazepam propranolol combination is available. I use this clonazepam propranolol combination in people who have claustrophobia. There are people who have difficulty in lying down for an MRI scan and things like that. For that population, this combination works well because the propranolol will take care of the peripheral symptoms, including palpitation, tremor, etc., while clonazepam will manage the cognitive symptoms of anxiety. A word about pharmacotherapy of substance use disorders among adolescents, which is coming up in a major way. It depends upon the type of substance which they use. If they are using tobacco, bupropion, which is a norepinephrine dopamine reuptake inhibitor, or nortriptyline, which is a tricyclic antidepressant, are effective. We can also give nicotine replacement therapy in the form of nicotine lozenges or nicotine patches. Chewing gums are not advised these days because a recent study has come that if you use nicotine chewing gum, if there is a precancerous lesion anywhere in your mouth, when you move the chewing gum randomly inside your mouth, this precancerous lesion can spread to other areas also. So if you need an oral nicotine replacement therapy, go for nicotine lozenges. Ask the client to keep the lozenges in one part of the mouth and don't move it. It will just dissolve. So that is for tobacco. For alcohol, we have got so many drugs available. Disulfiram is the one which is approved for use in adults. Disulfiram has its own problems also. It may worsen psychosis, it may worsen neuropathy, and it is contraindicated in anybody who is not capable of vomiting, because if they have major health problems, if they vomit once, recent head injury, recent surgery, recent abdominal issues, compromised liver function, etc., it may be avoided. Naltrexone.
Excuse me, sir. Arun,
Yes.
sir.
Yes.
We are extremely sorry to say, but due to lack of time, we have to wind up the lecture in
yes.
next 1 to 2 minutes.
Yeah.
We have
yes,
few
this is the
questions
last
also
slide.
that we are going to take at the end of the session.
This is the last slide. 1 minute and
Please,
I'm done.
thank you very much, sir. We are extremely sorry for that.
So naltrexone is very useful for both alcohol as well as opioid addiction. Acamprosate is useful for alcohol addiction. Topiramate and baclofen are useful for alcohol. N-acetylcysteine and gabapentin, they are very useful for cannabis use disorders among adolescents. And N-acetylcysteine has also provided some positive evidence for behavioral addictions like gadget addiction, etc. So that finishes my talk. Thank you very much for your very patient listening.
Thank you so much, sir. It was indeed an enlightening session for us, as we being general pediatricians, we due to lack of knowledge and information, we are reluctant to start pharmacotherapy for mental illnesses in adolescent. But your talk was quite enlightening and has given very good insights for us, which will be useful in day-to-day session. Now we will move on to our next session, that is counseling for adolescent in OPD for pediatricians by none other than Dr. M.K. Sinha, sir. Being a legendary in adolescent pediatrics in India, sir doesn't need any introduction. What I'm talking about.
Can we finish the questions to Dr. Arun? Some questions to Dr. Arun, finish it because
okay.
you lose track.
Okay, sir, we are planning to take it in the end if it is okay for you. After
No, but
the session,
they will forget after some time. I think
okay.
better to finish it.
Okay, so Arun Nair, sir, I'm just reading out the questions. So,
Yes.
yeah.
I'll finish fast. Yes, please.
Yeah. So, if less than 3-year child is having severe symptoms of ADHD, can methylphenidate be prescribed?
Less than 3 years.
Yeah,
Is
less
that
than 3 years.
Definitely not. To prescribe methylphenidate, the child needs to be at least 6 years of age. It is not good to prescribe methylphenidate for kids less than 6 years because it will definitely lead to growth retardation. So if you need pharmacotherapy for severe ADHD in children less than 6 years, 2 options. Number one is clonidine at the lowest possible dose. Or if the child does not have the habit of eating tablets, risperidone is available in liquid formulations. We can give bare minimum dosage like 0.25 ml in the morning and 0.25 ml in the evening. That may be sufficient to control the aggression in small children. That is better than giving methylphenidate. Thank you.
Okay. So next question by Dr. Shivarkar, madam. How early we can start fluoxetine, till how many days it is safe in children?
Fluoxetine is approved from 6 years of age in children. So for children between 6 to 12 years of age, for depression, better to start at 10 milligrams in the morning. Fluoxetine, as I have already told, is available in liquid formulation also. 20 milligrams in 5 ml, that is a liquid formulation. So the child is comfortable having liquid, give 2.5 ml of fluoxetine liquid in the morning immediately after food. And the duration of treatment for depression in children and adolescents is 6 to 9 months. That is the usual course. So maybe after 6 months, if the child is comfortable, we can taper and stop, no problem. If the child is not responding to 10 milligram, you can hike it to up to 20 milligram. In children above 12 years of age, if the depression is severe, you can start with the adult dose of 20 milligram itself, and if necessary, hike to 40 milligram. Advantage with fluoxetine is that you don't need to taper meticulously. You can taper fast and stop because the residual metabolites will be in the blood for the next 2 weeks at least. Thank you.
Okay. So next question by Dr. Chandrakant Survase. Role and dose of aripiprazole for reducing RRB in autism spectrum disorder.
Yes. Aripiprazole, it depends upon the body weight of the child as well as the extent of behavioral problems it is creating. Aripiprazole is available as 2 milligram, 2.5 milligram, 5 milligram, 10 milligram, 15, 20, and 30 milligram tablets. So if the child is a small kid, less than 12 years of age, 6 to 12 years of age, you can start at a dose of 2 milligram BD, one in morning and one in night. And if the child is not responding after 1 week, increase it to 2.5 milligram BD. Even after 1 week not responding, increase it to 5 milligram BD. It is possible that at a dose of 10 milligrams or more per day, the child may show akathisia. So if you think that the child has improved in aggressive symptoms, but the child is having something like a restless leg kind of phenomenon, it is good to add a low dose of propranolol in the morning, or maybe a low dose of etisolam at night. It may take care of the akathisia if all the other symptoms are improving well. So for autism spectrum disorders, maybe up to 10 milligram may be sufficient. But if the child is about 12 years of age, you may have to hike the dose to up to 30 milligram. Up to 30 milligram is approved by FDA for autism spectrum disorders for aripiprazole. Thank you.
Okay.
Trupti madam, let's go for the next talk immediately.
Okay. Okay, sir. Yeah. For next talk, I would like to invite none other than Dr. M.K.C. Nair, sir. Sir, being a legendary in adolescent pediatrics in India, doesn't need an introduction. What I'm telling here is just a decimal of his entire career. He is the emeritus professor in developmental behavioral and adolescent pediatrics in child development. Considering his academic excellence and professional contributions, he was offered the position of Vice Chancellor in the prestigious Kerala University of Health Sciences. He is a renowned academician in the field of clinical child developmental pediatrics. So we are privileged to have you on the dais of PATH twice in last 5 months. I hand over the virtual dais to you for your next session. M.K.C. Nair, sir.
I can't find the screen.
Yeah, I can't see, sir, actually.
Is he angry or something? Can you call in?
It seems as he has exited from the meeting. I think there should be a technical error.
Reena, will you call him?
Actually, for those questions who have not been answered by Dr. Arun Nair, sir, we have an upcoming issue of Child India for the May 2023. And he has written the same topic article and everything in a table format, which we can keep in our clinic table. And all the drugs and everything has been described in depth. Can be very handy in our day-to-day adolescent practice. But I am really wanting to know where is Dr. M.K.C. Nair, sir?
So I have Reena is calling him.
Could I ask a question in the meanwhile? Hello?
Is she successful?
Hello. Hello, everyone. MKC sir is joining in next 2 to 3 minutes. There is sudden power failure at his place. Meanwhile, Trupti, can you ask the question, ask the chat box, Arun Nair, sir?
Yeah.
So we will save the later time.
Yes.
Yeah. Thank you, Pidisha. Arun sir, it will be okay for you?
Absolutely fine.
Thank you, sir.
So next question by Dr. Swati Ghate, N-acetylcysteine dose for gadget addiction.
Yeah, in adolescence, we give it at a dose of 600 milligrams thrice daily to begin with, because it is costly. But the thing is that at 600 milligram once or twice daily, it does not produce much kind of an effect. The craving for this gadget addiction is very similar to the craving for certain substances also. The changes which are happening in the reward pathway of the brain, the mesolimbic dopamine circuit in gadget addiction is very similar to that seen in cannabis and stimulant addiction. So at a dose of 600 milligrams, 111 for at least 12 weeks, it produces good results in the case of gadget addiction is what we see.
Okay, so I think sir is here.
Okay, Arun, I think they needed few more minutes with you. That's why the power failure happened. Okay,
Okay, sir.
Arun has given a very high stuff for pediatricians. I will talk about more simpler things, what can be done on an OP basis. Okay, so it's a counseling is a skill and art. There is some amount of knowledge, but more than knowledge, it's a skill and art. So I think remember that you have to catch the skill. That is the most important thing to remember. Let's start with what I started in the 80s. I was in CMC Ludhiana, where I used to refer.
तू बाहेर आहेस? Sorry.
Can you hear me? Can you hear me well? Okay. In 80s, I was in CMC Ludhiana, where, can you hear me well, everybody?
Yes, sir.
Yes, sir. Yes, sir.
Okay, okay. So where Dr. Kala was a psychiatrist, I used to refer cases as a PG. And when I go for lunch, I have a discussion with them. That is how I got introduced to counseling issues. Of course, I wanted to become a psychiatrist, but then decided not because those days, it was not all that good thing to do. So pediatrician was better. But the reason why I got interested in counseling was because there is a stigma that Arun was talking about. Even now it is there across the country. You don't want to go to a psychiatrist, though it is better now. So what happened in 1980, February 7, my good fortune, Mrs. Indira, who just came from Nimhans, Bangalore with MPhil started. So we revived a dead child guidance clinic. And just look at 1 year, one particular year data, how much? You are talking about 1 year data, about 2,045 children seen in a year. What are the things the most important a pediatrician would see is scholastic backwardness, 70%. If you are doing behavior issues, scholastic backwardness is the maximum that you are going to see, which of course may be environmental factors. It may be little sub-minimal IQ. It may be frank mental retardation or intellectual disability, maybe ADHD, or few cases of specific learning disability, which is actually being diagnosed much more now. So just think of these 5 conditions. First thing, have a look at the IQ somehow. And whichever method is available with you or in your neighborhood or with your colleague, do that. Then environmental factors it may be school related, it may be home related, it may be something very personal. Internalizing that, he was talking about, Arun was talking about internalizing and externalizing behavior. So some of them internalize, we don't realize. They will sit quiet. We won't know what is happening. Whereas externalizing ones, we will immediately pick up they are aggressive, they are a little difficult child. Then, of course, conversion reaction. Conversion reaction, I'll come back to it, is probably, I have the good distinction of having published the largest number of conversion reaction, 500 cases of what we used to call hysterical conversion reaction in the Kerala Psychiatric Journal. And I will talk about it a little more later. Then, of course, behavior problems, where is oppositional defiant behavior or conduct disorder. Oppositional defiant is a younger brother of conduct disorder. The fellow start using aggression, little minor sexual offenses, stealing, all that. Then he become conduct disorder. But if it is just like a exaggerated toddler reaction, no, I won't do. What will you do? That behavior with toddlers we tolerate. Suppose you do that, then that is an oppositional defiant disorder. Then, of course, you have speech problem, not only stammering, whole lot of speech problem. Now, in simple words, speech problem, we will say SODA, substitution, omission, deletion, addition. SODA, SODA. SODA is the way we use the type of speech problem that can happen. Then you have fear, anxiety, and one word I think you must remember more is a separation anxiety and school phobia. We have done a lot of work on this. And separation anxiety has come as a separate distinctive condition in the DSM-5, because I think we must realize the separate. One typical example I will say, a child was sitting so, depressed looking in the class. Teacher reported, child was brought. What used to happen is the father will say, every day morning, when the father leaves, mother will say that when you come back, I won't be here, which means she is threatening to commit suicide. Okay. The child whole day is wondering whether mother will be there when I go back. So that is a problem. But the father, when he come, surely the wife will be there. He will curse himself. Okay, today also nothing happened. You understood? So the difference between the father and the child is different. Father see it in a different way. The child see it in an anxiety stage. So this is exactly what I was saying. Poor school performance. You need to look at the environmental factors. But one word I must say, one thing I learned from Paul Russell, he is my guru in psychiatry. And what I learned from him is, he says, never go make a diagnosis from the history. If you take my history, there'll be plenty of factors at home, factors in the office, factors in the society, which doesn't mean I am mad. I have no problem. Okay, because I have the capacity to manage it. But so don't go around asking for all the detail. First, see whether the child has any problem, and the diagnosis should be done by classical way of diagnosing by DSM criteria or by simple tools or tests. Once you make a diagnosis, then you go into all the details, what probably has led to it, what is maintaining it, or what is exaggerating it. I hope I want you to listen to this very carefully. We all make mistake that you have a problem there. Oh, naturally, that's why you are depressed. No. First say whether you have depression or not. If you have depression, on what scale have you decided it? Is it clinical? Is it DSM-4, 5, or is it by a tool? Then get into the reason, because that reason is important not as a causative factor. Reason is important only as a factor to reduce the problem. So that is important. It could be a lack of minor intelligence problem, some subject problem. It could be poor fit with the teacher, but always remember mental illness, which mental illness doesn't mean not huge ones, maybe depression and anxiety. Then what is a conversion reaction? This is something we need to know. The child make a dramatic presentation, and the moment you solve it, there is a dramatic improvement also. Okay, that's a very important thing. A classical example, I'll tell you. A child was brought to me. Hundreds of examples, but I'm saying child was brought to me here. He will not. He cannot move the arms. Pediatric neurology professor also certified there is no problem. Naturally, that is very important. And then what happens? I just dialed his father's number. I didn't know the number. I just called him number, just show that I am dialing. I gave to a child, caught on it. So if I am a fool, I will say, look at this child was malingering. No, conversion reaction is not malingering. They actually have a problem in moving the limbs, which do not have a physiological basis, but it has a psychological basis. Understand that. They are not cheating. They are not bluffing. They do have a problem. Only thing is, when you do the blood test or do a neurological examination, you won't find anything. But when you do the psychological examination, you will find enough reason. So don't blame the child. Don't make fun of the child. And please take the situation seriously. And you will, one by one, when you analyze, you will be able to give therapy. In other words, symptoms are real experiences
So we cannot hear you. Hello, sir. I think some network issue by sir's side. Let's wait for a few minutes for him to rejoin again.
Trupti, kindly mute Dr. Manakral, sir.
Yeah. Just a request to everyone. Am I audible?
Yes, you are audible.
The environment is quite windy here also in Nasik, and there might be temporary disconnection of the network from my side also. So if it happens till I get switched onto the another network, please wait for a few minutes and rejoin the same link again. Because we don't want, I want the program to run smoothly. So I'm just telling everyone that the environment is not very good over here also. Rina, will you call up sir again?
Sure, I will do.
Here it has started raining already.
बाहेर जाळून टाकू ना मग काय
Dr. Manaklal sir, I request you to please mute yourself.
जाळून
And stop the video also.
Yeah, I did that.
So I think the counseling is
अतुल
not
सर,
working.
माझ्याकडनं नायर सरांना कनेक्टिव्हिटी इश्यू येतोय. एकदा तुम्ही कॉल अप करून बघता का?
No, he has some problem there.
नेटवर्क इश्यू आहे. हो, इलेक्ट्रिक.
I'll try it, but he is also must be very eager to join back. No?
Trupti, if there are any question, can we continue with Dr. Arun sir?
Yeah, sure. So
Because if counseling doesn't work, then psychopharmacology only will work.
Don't worry, counseling will work. I'm just
Yes.
coming back. Don't crack your jokes. Counseling will work. Just wait for a minute.
Yes, sir.
Meanwhile, you
Again gone, sir. Trupti madam, you start your questions if there are any for Dr. Nair, Arun B. Nair.
yes, sir.
Let's not waste time.
So one or two questions were remaining.
Yeah, he's back. Sir is back.
Okay, great.
Sunday happens to be the day of all power failure. So now I'm working on the mobile.
Okay.
Okay, I'll try to go first. Okay, we know that we started this IAP adolescent way back in 2004. Now let's get into the simpler thing. I'm sure some of you have heard this many times, but I think still it is important. Advice is one word we use. It is old stuff. No, present day children don't want to hear it. Whereas guidance is something which children will take it because you are taking their opinion also. In guidance, actually, you just give the facts and give the decision to them. If you do like this, it is likely to happen like this. If you do like this, likely to happen. Better you make the choice. Then they don't mind it, listening to it. Marriage, of course, negotiation. I don't know, this is my personal view that never negotiate with couples. Never do that. You take the wife as a separate OP number, take the husband as a separate one. If she has problem living with him, you counsel her what to do. If he has problem living with her, do it. But don't try to, put them together. Most often, you will be the culprit in the end. They both will blame you. So don't do that. Psychotherapy, of course, we are not qualified to do psychotherapy. It should be done by a psychiatrist or a clinical psychologist because you are going to unconscious mind, not even subconscious. Sometimes you may have to go to unconscious mind by many methods like after reaction and whatnot. So leave to Arun for that. We won't do it. But counseling is what we can do. Counseling is basically improving the personal growth. What are the things you should know about counseling? When you are sitting in OP, you don't have a lot of time to go into the whole process of counseling. So quickly, you may have to spend 5 to 10 minutes maximum for counseling. What do we do? Understand that counseling is not advising. Understand that counseling do not solve all life's problems. Counseling is aimed at helping people make choices and act on them. This is the only word you need to remember. You are not giving choice. We are equipping the person to make choices depending on the context from where they come. He understands, she understands her context, the background, the problem, what can happen. So based on her interest, what is the most appropriate thing to do to make choice? So if anybody asks you what is, counseling, it is helping a person to make choices. That is the most important word. It's a learning process and actually develop a personality development. Now, 3 words in psychology, which is fundamental to psychology, that is cognition, conation, and affect. If I say something, if you are favorable, inclined to me, whatever I say, you will take it as nice. But if you are already angry with me, then what happened? Whatever I may say, you will take with a tinge of negative. Because your behavior is dependent on your affect or feeling towards the situation, feeling towards the person, feeling towards anything in the world. Okay. So when somebody is telling you something, the initial reaction will be affect or feeling. But after 30 seconds, you must go back to the thinking one, look as a third party and see whether what he said had some meaning. Did it make any sense? I may not like him at all, but what he said may be useful to him. So you learn to think rationally, and that's the most important part, because you are going to get rid of illogical, irrational attitudes and thoughts. And so long as you have irrational, illogical thoughts, you will never be able to come to this. And that's the most important. And we understand the word cognitive dissonance. That is important. You actually have completely confused situation. Whereas thinking wise also you are completely confused because a counselee has too many problems. He doesn't know do this way or that way and all that. Whereas a counselor should not have cognitive dissonance. So affect means feeling. I have already covered. It is based on a Rogers principle of client-centered approach, and where we focus on elimination of defense mechanism. We all do defense mechanism. Every moment of our life, we are going on defense mechanism. Once you understand that, yes, I am doing a defense mechanism, don't tell the other person it was my defense mechanism, but at least tell yourself. And that's why the whole concept, a new concept coming called self-counseling, which I am working on now. It is actually you tell yourself that, yes, I was just doing a defense mechanism. And if you want to learn this, you talk to politicians. They are the best people on earth. They use all sort of defense mechanism, but they will laugh inside, but they look so serious outside. Outside you may have to do. Then whatever be the initial feeling, within 30 seconds, switch over to cognitive. That's the most important. Now, phonation of behavior is based on learning theories, where if you have learned a bad one, relearn a good behavior. Remove the bad one, relearn a good behavior. Okay. Now, this is most important. Core conditions for counseling. Empathy. Empathy, we all have sympathy, but we actually don't have empathy. And in fact, what COVID, if you ask me what COVID has done, it has taken away completely our empathy. And we have become so stiff now. Somebody has died. You are simply not bothered because somebody has COVID. You are not going to visiting. All our thrill. Oh, he's my relative. He's my friend. I must go and visiting. No. How can you go when there is COVID? Now, this idea has happened in the family also, even between brothers and sisters and cousins also. Seclusion, segregation is becoming too much. So COVID has done a lot of damage to our feeling of empathy. When a child come in front of, if you can see as your own child, not ever, only for that 30 minutes or 15 minutes, you have to look at the child or girl or boy as your own child and then say, think from his point of view or think from when you were a child, then that is empathy. You must have unconditional positive regard. Don't think of somebody as a valueless person. You know that incident when a fellow very badly dressed walked into a restaurant, they said, get out. You sit in the outside and eat. Okay. He was sitting outside and eating, but when he finished there, he gave a big tip. Whereas the fellow, coated booters fellow whom you received and sat inside, just gave him 100 rupees. This fellow gave a 500 rupee note. Can you believe it? So don't assess people by the way they look, by the way they believe. Every human being has value and worth. Otherwise, you cannot be a counselor. Congruence, feeling, thinking, and action should match. The client comes to you because they think something, they feel something, they behave something. They are confused what to do with this or that and all. So congruence has to be there for the counselor, not for the counselee. A counselee doesn't have congruence, that's why they are coming to you. Respect, make positive statement. Very important. Never make one negative statement. We all say things in fun. I stopped doing that because, once a small child, I called him Gundumani. Gundu means, the fat one. Next time, the child refused to enter my room. It's a small child. And I was surprised. Even he has that feeling of worth and ego. So I literally had to apologize to the child. I was only joking, but I will not joke again. So remember, even what you say as a joke can be hurting to that person. Respect and immediacy. Now, one of the mistake, in fact, last week a patient came, he went somewhere for counseling. He said, sir, I don't know what that beggar was telling. This is the word he used. He keep on telling about international things, this, that, and all that. I went for a purpose, maybe to explain that he was talking international, but don't go like that. What is your problem? What can be done for that? What do you think can be done? How can I help you? Finish. That is enough in counseling. Don't try to, give a old time stories and all. Confrontation, soft confrontation is point out discrepancies. This is not what you said last time. You said you really liked her, but today you are talking in a very different way. That is confrontation, simple way. The real hard one may be somebody talk about husband, all sort of bad. In the end, he say, get rid of the rascal. Huh? No, sir. No, that I don't want. So that is just to know how far she will go. That may be also a bad type of confrontation. Concreteness, discuss in specific terms. They have come for a specific problem. Don't go beat around the bush specific things. Self-disclosure. Should you tell your personal things? No, you can't, because otherwise the boys will start asking how many times you masturbate. Actually, one boy asked me, sir, how many times you do? Then I said, if you want me to know that, you sit on my chair and I will sit on your chair. Understood? If I am coming to you as a client, then you can ask me about it. When I'm sitting as this one, you don't have to say. But having said that, Indian clients, how much you explain, they expect you to say what you do. Then sometimes you may have, especially the villagers, they are so used to somebody tell them what to do. So you may have to do, but although legally not correct. Now, this is the most important steps for counseling processes. Positive ventilation, positive relationship building. How to make it is different for everybody. One classical case I will tell you, which actually led to me getting a lot of positions in the CDC. Son daughter had a problem. She came and sat in front of me looking like this. Go to hell. I'm not bothered about you. Naturally, you will get irritated, but a counselor not get irritated. I kept on waiting and then started looking at me. Then we started looking into eyes. So that's how you start a good thing. Now, ventilation or catharsis means let the person talk. And when the person talk, do not unnecessarily interrupt and do not ask direct questions. What did you do there? No. How was the feeling? What was your feeling? How did you feel? Give a little more broader thing so that they can keep on talking about, not yes or no question. That is what we've been taught in the guided counseling program. I think in the training program, we conduct a lot of guided counseling. So a person sit there and say, see, sir, you are asking now direct question. Can you ask in this way? If you ask, then the person get a chance to keep on talking about the conversation. So never ask, did you feel bad, good or bad? Answer me. No, nothing like that. What is the feeling at that time? How did you feel when you got your exam result? That may be a better way of asking. Then client's role in the problem, which is, I believe, is not there in any of the counseling books. Most of us make noise because we think we are always right. The other person think they are right. But the philosophy says both of us are right and wrong, and the real truth is something else. So we never think of what is your contribution in that fight. Okay. If you have a problem with your child, what is it? You only talk about the way the child will behave, but you also think that how did I behave to the child? Did I make a contribution? That is very important. Then context of the problem is extremely important, because every solution cannot be solved one way. A very poor mother with 3 or 4 girl children to marry off, she may have to tolerate a husband who is maybe drinking, even beating. By law, you don't have to. But the fact of the matter is that she may have to tolerate a little bit. Whereas somebody is very, the girl can live on her own. She is educated, she has job, she may not bother. So that may be the way. Prioritize problems, just like prioritize solution. First, I said prioritize solution. Out of 100 problem you have, tell me 3 things that we need to address immediately. And from the 3, come to 1. Similarly, for each problem, you say 3 solutions, discuss those solutions and say what can be, which is the best in your context. But that you don't say, you only encourage the person to make the thing. Then help implement the solution and the counseling should be terminated. Now, what are the problems that we can have? 3 types of problems. 1, unresolved childhood disorder.
Problem again?
Yes, sir. Very much informative and interesting session going on, but unfortunately, we can't do anything for the natural calamities. So I request everyone to please wait patiently till sir joins.
You can finish one question with Arun Nair, sir, if he is there.
Yes. Is he there on the platform?
I don't think. Few minutes ago, he said he has to go for a meeting or something.
Yeah.
Now we can see Maniklal Chopra sir's left ear. See? मुद्दाम करता है ना क्या?
Yeah, I can see Nair sir.
You can see?
Yeah, but he's muted. Dr. Arun Nair sir, are you there? MKC sir has got disconnected. So if you're there, we'll take the remaining questions.
We have only 5 minutes remaining.
Yeah.
Good. 52 participants. And YouTube, I don't know how many.
So today it was really, it's really wonderful session which is going on. And if you remember the third session of PATH, we have learned about interviewing of an adolescent through head screening.
Preeti, stop.
Yeah, by Dr. Preeti Gargali, madam. And today's session has enlightened us about psychopharmacotherapy in adolescents and counseling.
Yeah.
Now we have got almost complete overview about dealing with adolescent in our OPD practice, right? How to start and how to end with the pharmacotherapy and counseling. Really a great session.
Actually, at the end of this year, madam, we'll have such many more sessions. Now this is, I think, the 5th session. So still 5-6 more to go, and then at the end of the year, we'll have a really. Sir has joined, I think.
Sir has joined, yeah.
We can see you, sir.
Okay, now these are the things that Arun was talking. We must realize the children may have generalized anxiety. It may be phobia. Fear is not phobia. We need to remember. Fear can be mild, moderate, severe. But the phobia is different because phobia will have autonomic symptoms. Because fear is more depending on the threat, whereas phobia is not dependent. You have a cockroach, he is not going to eat you up, but you jump out because not because of gravity or the threat. It is because of the sudden autonomic reaction.
Again gone, sir.
I think again there is a problem from sir's side, unfortunately.
I think sir can work from his laptop and speak from his mobile. Is it possible?
Yeah, if mobile, yeah, he can talk actually.
We can use his laptop for sharing the slides.
Sir, screen will not be shared if network connection is unstable. Means he has to connect his mobile to laptop through hotspot. If he's
Doesn't matter. Let him just have a video call.
Yeah. Arun Nair sir is there. Sir, can we take 1 or 2 questions? Remaining questions till sir joins back?
Very much. No problem.
Yeah, so one of the questions was, what will be the dose of fluoxetine in anxiety?
Okay. Again, one problem with fluoxetine is that it can produce paradoxical anxiety during the initial couple of weeks. It happens very often, especially because fluoxetine can produce a little bit of gastritis also. So this gastritis can manifest as an autonomic disturbance, then it can lead on to palpitations. So first 2 weeks, it can have a problem. So in anxiety disorders, if you are prescribing fluoxetine, kindly co-prescribe it along with the benzodiazepine for the first 2 weeks. And also ensure that you sandwich fluoxetine in between food when you prescribe it, because half the food has to be consumed, then take a capsule or tablet of fluoxetine, then complete the rest of the food. That will prevent this gastritic symptoms. So start with 10 milligram itself, but first 2 weeks, you can give a low dose of an benzodiazepine like etizolam. That is what I usually give. I give 0.5 milligrams of etizolam also for the first 2 weeks. After 2 weeks, I taper it into 0.25 for the next 1 week and take it off. So by 3 weeks, the action of fluoxetine will fully get established. And by the time you can taper and tape off etizolam also. That is a better way in anxiety disorders.
I think Trupti madam, are you there?
Yes, sir.
Okay. We just have, I think, 2 to 3 minutes left.
Yeah.
Can we have some program where we can take this topic again, MKC sir's topic?
Yes.
If it doesn't work out today, because this is a very important thing as far as practicing pediatricians is concerned. And counseling, unless you can do counseling in a better format, there is no point in just referring all the cases to the psychiatrist or prescribing drugs like general practitioners prescribe antibiotics and all that. So basically, the focus should be mainly on counseling and then filtering out those cases which need the reference to psychiatrist. Do you agree, Arun sir?
Very much, sir. Absolutely. Because a large number of cases, pediatrician can manage at their level itself. You need not spend too much of time. Even 5 minutes of quality time you can give. There is something called solution-focused brief counseling. It's a very useful approach for pediatricians.
Useful.
Minimum time, you can deliver some stuff and address specific issues without wasting much of the time.
And we can filter out those few cases which need referrals and in fact drugs also. Also the cases can be tackled by counseling if we are well equipped with the skills and the patience that we need.
Yes.
So I think this topic needs undisturbed sort of quiet talk whenever we can have next time. The Nasik AHA being the host team can definitely look into this matter. So, Reena Rathi madam, Sucheta madam, are you there? Do you agree with this?
Yes, sir. Yes, definitely.
This
We'll
is
do
a very, very important topic for everyone, and I think we should have an elaborate, good, uninterrupted talk on this particular topic by Sir MKC sir. So, I think it's 12:30 already. So, if we have any questions for Arun Nair sir, we can ask and then convey this to MKC sir whenever possible that we will have this session in a fresh mood, uninterrupted, and when
Yes.
there is no technical, problem at that time. So, if you have any questions for Arun Nair sir, please go ahead, madam.
One question is there in the chat box by Dr. Ghate madam. What drugs do you prescribe for ODD and conduct disorders?
For conduct disorder, essentially, we have to control two aspects. One is aggression and second is impulsivity. These are the two targets for pharmacotherapy in conduct disorder. So one drug which addresses both is a low dose of risperidone, maybe 0.5 milligram to 2 milligram. That is the usual dose. And if it is a female, definitely don't give risperidone, give aripiprazole, because female adolescent, we cannot afford a prolactin. So 2.5 milligram to 10 milligram of aripiprazole. That will take care of both. For ODD, ODD is a condition in which the behavioral problem is manifesting only in a particular setting, maybe at home alone. The person is well behaved elsewhere. So for ODD, you don't need pharmacotherapy as the first line. behavioral modification, as we call it. That is what is necessary. So in behavioral modification, we do these things on, there are 3 theoretical frameworks for that, something called classical conditioning, operant conditioning, and social learning. Using these 3 theories, one thing you can do is you can reward and punish the child appropriately. The child is demonstrating very positive behavior, positively reinforce it and negatively reinforce it so that the frequency of that good behavior is enhanced. And in punishment, what you need to do is you can withdraw the privileges, passive punishment. That is the first line which you need to do. Withdraw the privileges which we have bestowed on him, so that whenever he is showing an unacceptable behavior, just withdraw the privileges. Another step is extinction. Extinction means if he is showing very adamant behavior, he is continuously irritating you or demanding something, just ignore that behavior for some time. Behave as if such a person does not exist. So if there is no response for such kind of a behavior, the frequency of that behavior will gradually come down, and that is called extinction. So these 2 things can be very effectively tried. And some parental training also, we call it as parent management training. Parent management training is something which we give to all parents of kids having conduct disorder and opposition defiant disorder. There often it will be certain parental triggers which lead to worsening of the child behavior. So the parents will have to understand what is triggering the child and modify their expression of ideas in such a way that it does not irritate the child. That is one thing which is to be done. So positively reframing. So we do something called acceptance and commitment therapy. That is again a psychotherapeutic technique which is very effective for childhood behavioral problems. So accept the child with his limitations, but at the same time, understanding the limitations, do what is necessary to develop him, his potential, whichever is there, to the maximum level. So these 2 things combined, that will take care of ODD mostly. But if the parent is not psychologically minded and is not in a frame of mind to listen to you, or are cognitively not able to understand what your instructions are giving, maybe again the same line of management as in conduct disorder can be tried pharmacologically for ODD also. Thank you.
Thank you so much, sir. Now there are many questions which are coming in the chat box, but as we are already overshooting the time, I'll just take one last question for you. So could you give a brief about the Kerala Government School Mental Health Program?
Yeah, Kerala Government School Mental Health Program here. We have got mental health workers, or what you call the grassroots level mental health workers, who are assigned the responsibility of going to schools, assessing their mental health or understanding their major issues. We give them questionnaires essentially. They are not very well trained to identify mental health disorders. Essentially some questionnaires. One questionnaire which we commonly use is the SDQ, the Strength and Difficulties Questionnaire. Just got 5 domains, which include 4 domains which identify the weaknesses of the child, which include mood disturbances, attention disturbances, conduct disturbances, and behavioral problems. And 1 domain is about pro-social behavior. So after identifying these, if anybody has got certain problems which is above a cutoff, they are referred to the District Mental Health Program, DMHP. So the primary health centers, at least once in a month, the team led by a psychiatrist is going there. It is referred to that team, and the team do the necessary intervention at that level. If they need a further level of expertise, they are referred to the child and adolescent psychiatry units associated with medical college. Another thing is we have also done something called life skills education training for schools. We have prepared a module for life skills education called Ullasa Paravagal in Malayalam. It is published by the SCERT, State Council for Education Research and Training. So here for every class from 1st standard to 12th standard, 20 hours of participatory, process-oriented and experiential activity-based training is given. So after 1st standard, when he goes to 2nd standard, the activities will be a continuation of what he has been exposed to in the 1st standard. So like that till 12th standard. And I'll give you 1 or 2 simple examples. For a 1st standard child, we give us an activity like just draw the pictures of who are there at your home, the family members. And then we'll ask the child to just note down or tell how the father is helping you, how the mother is helping you, how grandfather is helping you. That is the way in which we try to develop life skills. And by the time the child is 6th or 7th standard, we introduce topics like substance use, unhealthy sexual practices. We train them in assertiveness. It is a very structured training, so that by the time they reach 10th standard, we have included career guidance and such aspects also. We have included a questionnaire on multiple intelligence, another activity on aptitude assessment also, which are inbuilt in that questionnaire. We have tried it out in 103 schools and the results were excellent. But by that time, COVID struck and everything has been washed out. And now from next academic year onwards, this year onwards, July, month of July onwards, again 100 schools have been selected and it is going to be implemented. So I think this is a physical and mental health promotional endeavor and a preventive intervention which addresses not only mental health issues, even nutrition, obesity, exercise, whole lot of things are there. So that is one of the important developments in school mental health in Kerala. Thank you.
Thank you, sir. Really a wonderful project and need of hour, I think. Now, before we conclude the session, I request everyone to please switch on their cameras to have a quick photograph. Just for 5-10 seconds, please switch on your cameras. Okay, at least I can see half of the beautiful faces. So thank you everyone for your patience and presence. On behalf of Maha IIT, I would like to thank both the stalwarts of today's session, Dr. M.K.C. Nair sir and Dr. Arun Nair sir, for their informative sessions. I would like to thank Dr. R.D. Patil sir, respected President Maha IIT, General Secretary Dr. Amol Pawar sir, and Chief Coordinator of PAR Dr. Atul Kanikar sir, who has arranged such wonderful sessions for training general pediatricians in the field of adolescent pediatrics. I sincerely thank all the delegates for their patient listening and presence throughout the session in spite of having many technical issues, and appeal all of you to join for the next session of the PATH, which are scheduled on first Sunday of each month in the year 2023. Thank you so much once again, everyone. And with this, I would like to conclude the session.